surgical emergency, and it is important to know what is cauda equina. L1, at L1, you have the conus, and below that you have the cauda, which means cauda means a horse's tail. So it means all the nerve roots are coming out there, and a large disc prolapse centrally can cause compression of all the nerves. And the biggest problem is it can involve bowel and bladder dysfunction. So to say that the person has cauda equina, he must usually have a saddle anesthesia, bowel bladder dysfunction, and variable sensory and motor function. And they don't follow a fixed pattern. So that is important to know. So they basically have bilateral saddle anesthesia, bilateral posterior buttock and thigh and leg numbness, and weakness with differential weakness of the legs, atrophy of the calves if it is long standing. So this is only surgical emergency. So as soon as possible, you should operate. And that is important. And because this may present anywhere in the country, and you may not get, as orthopedic surgeons, once you pass, you may have to know how to handle a cauda equina and operate on that. What are the investigations have already been said, but for diagnosing a lumbar disc prolapse, MRI is probably the investigation of choice. However, X-ray is very important, especially when you decide to do an operation, because level sacralization, lumbarization, 4 lumbar vertebra, 5 lumbar vertebra, and all that can be confusing. And so the commonest mistake if people do while doing surgeries, if they have not checked with an X-ray and the MRI, the level is the wrong level surgery. So the commonest mistake in lumbar spine surgery is wrong level surgery. So we always check the levels, not once, but twice or thrice. Sometimes subtle lysis, spondylolysis may be missed. And so CT scan is very important. Facet cyst, facet arthropathies may also coexist with a disc prolapse in slightly middle age. So that is also important, but not always. So essentially are your blood test, your MRI, and an X-ray. For patients with multiple comorbid situations like diabetes, neuropathy, EMG and nerve conduction studies are required, because suddenly you find a patient with a complete foot drop, but with not some major compression, and you get worried. So sometimes you have a moderate compression and you may want to do a surgery, but basically the patient is suffering from a diabetic neuropathy. So essentially, when you have coexisting diseases, it's very important to get EMG and nerve conduction test, and that is to be kept in mind. So once you have made your diagnosis, at this point, I must say that when you are diagnosing disc prolapse, I have not put that slide, but it's very important that you must eliminate other diagnoses which can mimic disc prolapse. A pelvic inflammatory disease can mimic disc prolapse. Sacroiliitis or inflammatory arthropathy can mimic disc prolapse. Even prostatitis or prostate problems can mimic disc prolapse. Abdominal aneurysm can do that. Abdominal problems can do that. So many conditions can mimic. So you must do a thorough examination. It is very, very important, and take a proper history. Once you have made up your mind that this patient has got disc prolapse and no other problems, what is the treatment plan? Most 90% of the disc prolapse, he resolved with conservative treatment, mainly with analgesics, some anti-inflammatory, and at best, very rare cases, you may give them a short course of steroid for 2 to 3 days. Bed rest is only for pain relief, so there is no role of major bed rest. As soon as he can get up and walking, I allow my patients to walk. Once the pain is resolved, then you start focusing on a long-term rehabilitation. So physical therapy is very important. So let us look at this disc prolapse, because when you graduate and become consultants at different places in the country, suddenly you get an MRI with a large disc prolapse like this. And I have seen a lot of times patients getting operated for large disc prolapse because it occupies almost 80% of the canal. So it is very important to know that sequestrated disc normally resorb because of macrophages, phagocytes, and things like that. So they resorb over a period of time. And you can see these two MRIs on presentation, and 10 months later, the disc has completely resolved. So most of the disc prolapse resolve, and size does not matter. It is one thing here. And this very good paper, which has been published recently, it says the percentage of spinal canal occupied by herniated disc does not predict which patients will fail non-operative treatment and require surgery. In this, the exclusion criteria, they've excluded cauda equina and hard disc and other things. But basically, if you have a large soft disc at L4, 5, L5, S1, and he has no more motor deficit or neurological deficit, no bowel bladder symptoms, you can treat him conservatively, and most of them will resolve about 6 to 8 weeks time. Any other role of conservative treatment? Traction has no proven benefit. There is no class evidence, and bracing is also not beneficial, but helpful in patients because it gives them some comfort of support. Now, epidural steroids are very commonly used since my early post-graduation days in Safdarjung. I've seen caudal epidural being given in bulk. However, caudal epidural as a route for giving steroids has gradually gone off, and nowadays we either give an interlaminar approach or a transforaminal approach, which is more specific and better and has got better outcome and more predictable. You can exactly see, localize where your needle is, and you can check with the dye, and then you give the injection, and they gave a very good result. In my unit, we do a lot of these blocks ourselves, and they give good results. So if a patient is being treated by you for conservative disc prolapse, how long do you wait? Essentially, if you wait too long, the nerve gets memory, gets scarred, and the patient is symptomatic, especially if a foraminal or extraforaminal disc, and so you don't get a very good outcome. So essentially, waiting for beyond 8 to 12 weeks is not beneficial. So if your patient is not getting better by about 12 weeks, that is 3 months, then it is advisable to go for surgery. Normally, patients don't wait that long, but you can wait as long as the patient has no deficit or problem. So what are the indications for surgery? I just told you 90-95% of disc prolapse resolve with conservative treatment. So what are the indications for surgery? So there are only 3 indications for surgery: cauda equina, progressive motor loss, and intractable pain where the patient wants that he can't live like this anymore and he wants surgery for better quality of life. Microdiscectomy still remains the gold standard, and all the other newer methods of discectomy are comparable to microdiscectomy. So still this is a gold standard. And if you can do a good microdiscectomy well, I think you are fine in treating the patients effectively, because you should not do any harm. And the complication rate of dural tears, discitis, or root injuries with the microdiscectomy is less than 2%. So let me take you with some schematic diagrams, because I thought time doesn't allow us. So you give an incision between the 2 spinous processes. You give a midline incision. Lumbar fascia, you can go slightly off midline, and you can see then you have the multifidus muscle. And the multifidus muscle attachment, as I have shown, is there. So you erase the multifidus muscle with your cautery, and then you will have to nibble it with your kerrison ronger or a burr. So once you nibble it, you have this much area exposed. The ligamentum flavum is attached slightly higher up on the undersurface of the lamina at the higher vertebral lamina, while in the lower laminar, superior margin of the lower lamina, it is attached. So if you put your kerrison ronger inadvertently lower, you may damage the dura and cause a dural leak, while you are much safer by putting the kerrison ronger superiorly, as you can see in the diagram. So once you have removed with the kerrison, you will have the ligamentum flavum. So the ligamentum flavum is attached higher up in the bone in the lamina above and on the margin in the lamina. So this is one safe area where you can start removing the lamina, or you can incise the lamina. There are many ways. You can keep the lamina, take a fold up, whatever you want to do, but you have to remove, raise the lamina. And once you raise the lamina, you will see where the disc prolapse is at the level of L5 S1. The disc prolapse is at the level of the foramen in the window, the foraminal window. As you grow higher up, excuse me, higher up, you have to cut more and more lamina. At L2, 3, you may have to do an hemilaminectomy as well. So this is a prolapsed disc. If it is on the shoulder, you can easily take it out. If it is in the axilla and it is very tight, then you may have to tease it out of the axilla. So this is how a disc prolapse is done. And then usually it's about 1.5 centimeters incision. So there are, as I said, there are various types of disc prolapses, and I can't go into details because Manish wants to teach the whole of spine surgery in 2 hours, which is impossible. So essentially in a sequestrectomy, we do a word which is called removal of the sequestrum, which essentially means we remove the free fragment and we go through the tiny hole or the tear that is there in the annulus, and with a 2 millimeter Kerrison pituitary, we take out whatever free fragment is there. So that is called a minimal sequestrectomy with removal of free fragments. However, when you have a cauda equina which is occupying the whole of the canal, you will have to do an aggressive discectomy. So if you do an aggressive discectomy, then you will end up with more back pain. But sometimes you have to do that, and it is important to counsel this patient. For example, this patient, you find that patient has 3 disc prolapse with a large disc prolapse leading to cauda equina, and this patient may have higher incidence of back pain. And if I do a sequestrectomy with just removal of the free fragment, I may have a higher incidence of recurrent disc. So this is a trade-off. And once with experience, you know how much to do and how much is enough. And that comes with only experience. There are lots of complications. So with discectomy, this is the simplest operation and yet the most complicated. And it can take 20 minutes to multiple hours. And sometimes you may come off after a surgery, which has happened with me so many times, where I'm not happy with what I have done. So it is very important to plan your case very well and know what you're doing. So don't take these cases lightly. You can have vascular injury, and there are reports that the patient, where surgeon has gone far anterior and nibbled onto the abdominal aorta and caused vascular injury. Nerve root injury is fairly common. Dural tear is also common. Infection, obviously you can have infective discitis, post-op discitis, and that's a nightmare. If you get infection in spine, it is a big nightmare. Or in other matter, if you get infection in spine or joints, it's a big problem. So we are very, very careful. Back pain increases if you do in aggressive discectomy. Recurrent disc herniation occurs about 6%, 4 to 6% in normal population. In diabetics, it is more. In smokers, it is more. And obviously, the amount of discectomy you do, it depends. And the amount of annular tears. I'll tell you a bit about annular tear, but there's not much time. So if you have a large annular tear or a defect, then the recurrent disc herniation chance is more. If you have a very small annular tear, the chance is less. Cauda equina is a big problem, and then there are medical complications. Two slides on what are the types of disc. Mentally, everybody would think that the disc prolapses when the annulus gives way. Yes, about 50% of disc prolapses when the annulus gives way. And the annulus can have a small hole, may have no hole, or may have a large hole, or may have a large tear. So depending on that, the outcome has also been described by this very good study, which is quoted most of the time, Eugene Carigi et al. And it tells us that which disc prolapse in which type will do well. Also, I would suggest all postgraduates to read this landmark paper from Dr. Rajshekharan, Ajay Shetty, and Rishi, which did a very good study, because MRI does not show the bone end plate well. And X-ray also does not show the bone end plate very well. And they found out that about 50 to 60% of disc prolapse occurs because of end plate fracture or rim failure, and 50% occurs because of annular failure. Until date, we always knew that disc prolapse occurs because of annular failure. And this is an important thing to keep in mind, because you must know all the things that are happening with this study. So the take-home message is history and clinical examination is very, very important in making a diagnosis. And I think must thank Manish for giving 3 lectures for only history taking and clinical examination. We have had a special class on MRI and how to read an MRI and X-rays. Most of the disc prolapse are treated conservatively. Only absolute indication is cauda equina or increasing neurological deficit or intractable pain. Microscopic discectomy remains the gold standard procedure. There are many more methods of taking the disc out, as endoscopic, interlaminar, transforaminal, and more minimally invasive procedures. But these 3 are more popular. And if you can learn these, well, you can give a better outcome with lesser complications. But it has a longer learning curve. And you must be aware of the complications and recognize them. And I thank everyone for giving me this time. I got this slide from Dr. Rajshekharan. He says, stay positive and test negative in this time of corona crisis. Well, there's so much of academics and no clinical work. Thank you, Manish.
Thank you, sir, for such an informative and good lecture. And I have received so many calls because there was some interruption in the YouTube. We have restored it. I request Dr. Anil Jain to be ready with his presentation. Dr. Shankar, you can stop the share screen and we can have few questions for Dr. Shankar. One or two questions. Dr. Anil Jain, can you hear me? Dr. Anil Jain?
Yes, I'm able to hear you.
Sir, you share your screen and we can have few questions for Dr. Shankaracharya.
I have a question to Dr. Shankar. Dr. Shankar, Dr. Kamran. Sir, one is that how much of disc would you remove when you are doing a routine discectomy, and when would you consider a fusion?
Shankar, please unshare your screen.
Yeah, I'm just doing that, sir. 1 second. Okay, I have unshared. You are all right?
Yeah.
Okay.
There is a question from
Kamran had a question, says how much discectomy is enough and when do you do a full fusion? So basically the answer is that it is a spectrum from 0 to 10. And as I said, you can go from just removing the free fragment to going to a full aggressive discectomy. And that it depends on case to case. So there is no fixed answer to that. But usually in present day, we do sequestrectomy, removal of the fragment. You should not cut the annulus more than 6 millimeters so that you it's a small incision. The incision should always be linear and not cruciate, as we used to study in our postgraduates. In linear incision should not be more than 6 to 7 millimeters. And then you use your 2 and maximum 2.5 millimeter pituitary to take out the free fragments. Don't use a curate or scrape it too aggressively. Don't take out the annulus, and that should be enough. However, if you have a large disc prolapse and a large annular tear, you may have to do it a little more. It is very rare in my practice that I do a primary fusion, but there is an indication of primary fusion in large disc prolapses, heavy patient, high BMI, and poor sagittal profile. And then Abhay says wine, dine, and spine to everyone. Well, there's nothing apart from water here. And so there is some small indications for fusion.
Okay, 1 minute. Because of constraint of time, can we go to Dr. Anil Jain's lecture?
Okay.
And we'll take questions later on. Vineet will take questions later because we have very less time. So at the end, because we have 3 lectures remaining. Dr. Anil Jain, please.
Yeah, thanks Manish for giving me this opportunity. Well, I know that 15 minutes too small a time to talk everything about TB spine evaluation and management. But what I will do, I'll just spend few minutes in the diagnosis and some of the tips which the postgraduate student must express in the examination. Well, we all know that it is an extrapulmonary tuberculosis, and as extrapulmonary, it is paucibacillary. So paucibacillary causes has its problem of lower bacteriologic diagnosis and source detection rate, and that's the reason why we have a little difficulty ascertaining the diagnosis in a spinal or extrapulmonary tuberculosis. And out of all, 50% is spinal tuberculosis. Now, if you look at the pathogenesis of disease, the disease starts as inflammation to the vertebral body, and that goes on to produce bone loss, bone destruction, to spinal deformity and neural complication. So this is the sequence of pathology, pathogenesis of the disease. Now, whenever you want to diagnose on clinical and on X-ray ground, where the classical clinical finding of a paraspinal tenderness, kyphotic deformity, some cold abscesses with or without neural deficit, and a classical X-ray finding which has been described as osteopenia, obliteration, reduction, and destruction of the disc spaces, and a kyphotic deformity, prevertebral shadows, increase in the prevertebral space, and the paravertebral shadows. So when you diagnose clinically in a with a deformity, probably we are already very late, and patient must be symptomatic for at least 3 to 6 to 9 months. That is why probably now we have to understand the pathogenesis of disease and move on making an early diagnosis where this classical radiological picture is not there. We have to diagnose it before an obvious deformity and a neural deficit. So for that, suspicion has to be clinical and clinico-radiological. Any patient with persistent back pain, localized back pain for 3 months or more, with or without tenderness or spasm, with or without constitutional symptom, and with maybe subtle radiological sign or without subtle radiological sign, is something which we need to evaluate by for sure by imaging. And well, in olden time it used to be multiple imaging, but now MRI is the gold standard. So these patients must be subjected for an must be put for an MRI evaluation. Now this is what I was talking, that it starts as inflammation and gradually the disc starts herniating into the inflamed vertebral body with the damage to subchondral bone. And as the disease continues, this destruction and inflammation continues, the whole disc herniates into the disease inflamed bone, and later on the anterior bone loss takes place, and that is how the kyphosis starts appearing, and the diseased tissue enters into the spinal canal to produce a neural deficit. Now this keep this pathogenesis in mind. Patient starts presenting with some pain at this point of time when the inflammation has started, with or without constitutional symptom. Further pain increases, local signs starts appearing, and if further ignored, then kyphos appeared or neural deficit appear, and it takes time. So now, if at this point of time you are able to get some X-ray finding like that, reduction in disc spaces, then we are more or less far sure that probably there is a definitely some underlying destructive disease or inflammatory or infective disease underlying. However, and that is why on this clinical imaging predictor, if you get all imaging, then we should be able to localize the lesion. We should be able to identify and diagnose the condition. Now, in the present time, all imaging are generally not used. So MRI remains the gold standard. So a presumptive case with a persistent finding of localized pain, and if these are subtle X-ray finding of increased localized prevertebral shadow and some straightening of spine or reduction of disc spaces, we should be able to diagnose with the MRI before a kyphotic deformity appears. And if you fail to subject and diagnose at this point of time, then I'm sure in some more weeks or in some more months, this kind of a classical radiological picture is going to come up. And that is what I was trying to, that if you understand the pathogenesis of disease, then we are able to diagnose before a classical deformity or neural deficit appears. Now, when an MRI has been done, then these are the findings which are very important. These patients, they have a contiguous vertebral body involvement. You could see these 5-6 vertebral body. Well, on X-ray, you may see 2 or 3 vertebral body, but 3 or more vertebral body may be inflamed. So contiguous vertebral body involvement, relative preservation of disc spaces, subligamentous extension, which is low signal in T1 and a bright in T2 weighted images, with large pre and paravertebral abscesses, which are septated. You could see this septated paravertebral abscesses, intraosseous abscesses, and epidural involvement. Now, with the constellation of these findings, we are now more or less 90% sure that we are dealing with a case of tuberculosis of spine. However, this is what is a clinical imaging diagnosis. Now, this is another example I'm putting here. Patient is symptomatic, and if you could see, there is a reduction in the disc spaces, and this vertebral body has anterior vertebral body erosion. This is another body which has erosion, and the MRI finding. You could see these are the contiguous vertebral body involvement, and this is the subligamentous collection, which is septated here. You could see bright in T2, low signal in T1, and intraosseous lesion. So now we are more or less sure, and this patient, we ascertained the diagnosis bacteriologically as well. So with these findings, in almost 90% instances, we are able to make a confident diagnosis. Now, on the contrary, if you have a heterogeneous signal with some normal intervening vertebral body, Now, these are not the patient or MRI picture to be taken as tuberculosis by all means. The differential diagnosis here, it's going to be sinister conditions like myeloma, multiple myeloma, lymphoma. So hence, we must take biopsy in all such cases. There is no place for empiric treatment as starting empiric ATT. Now, we have made a clinical suspicions, or we have done an imaging. So we have to ascertain the diagnosis either by some way, whether by MRI, where you have a classical finding. If not, then tissue, open or percutaneous biopsy. And once you have taken a tissue, then microbiological, molecular or histological diagnosis must be done. I think this is a very important slide, which I'm just going to show. And this slide is there in one of the recent clinical current concept review, which has been published in Journal Bone Joint Surgery American April issue. If you look at this triangle, then culture is the gold standard, which to ascertain the diagnosis in tuberculosis. And as I said, we are dealing with a paucibacillary. So in best of the lab, chances of getting a bacterial growth is somewhere between 30 to 50% in a virgin case. And that all depends on the quality of lab. Now, the next in hierarchy comes molecular method, which may be gene experts, line probe assay. Well, I've written data is not known, but now this data, some data has emerged in some of the series, and even we are likely to submit for publication one of the consecutive series of cases where molecular methods, gene experts and line probe has not only improved our diagnostic accuracy, but is also able to suggest or indicate if there is any drug resistance to rifampicin or rifampicin and INH in line probe is there. Now coming to FB smear, which is little lower than these two, and here again 10 to 30% instances we are able to demonstrate organism. Then the next is histological diagnosis. Now there are two kind of reports we get, as consistent and suggestive. Now if you get an granuloma proper and all other findings, then it is a consistent with tuberculosis. However, if the granuloma is not there, caseating granuloma is not there, then in that case it is always a suggestive. So 60% is if you take 100 histology, then 60% are consistent while 35% are suggestive. So these four methods are able to, if done all simultaneously, then we are able to ascertain the diagnosis in a paucibacillary spinal lesion in almost 100% instances, because each of the method is having some percentage of positivity. Now here, if you could see that radiological and imaging studies, clinical suspicion and therapeutic response to ATT, they are very low. And that is why confirmation, ascertaining a diagnosis in osteoarticular or spinal tuberculosis is a hierarchical diagnosis where you have to put everything together. Never rely on treating them on a clinical suspicion alone, or a only therapeutic response alone, or only imaging or and radiologically, unless your MRI finding are characteristic. Now, coming to the treatment, I think one thing is sure, that mainstay of treatment is a prolonged, continuous multi-drug therapy, and surgery is indicated in certain individual cases. Type of surgery, whether the patient has paraplegia or not a paraplegia, TB spine in children, granulomas or late onset paraplegia, these are the conditions which require individualized approach. Now, this treatment of tuberculosis has evolved after a BMRC study on 750 patients by British Medical Research Council between 1950 to 75, where 2 to 3 drugs, bed rest or ambulant, radical clearance or conservative, radical clearance or debridement were compared in different parts of the world. And it was reported that there is no difference on healing. There were many lacunae, but at least these study has conclusively proved that it is a medical disease to be treated medically. Now, evolution of drug therapy, there are many issues. What are the drugs? What are the volumes? What are the regimen, whether intermittent or daily dose? How long it should be treated? Is there any regimen difference in children? And failure to drug therapy. So these are the 5 questions which are put to students and put to our clinical practice every day in a different clinical situation. Now, rationality of this is a ATT is a multi-drug, because in a lesion there are various kind of organism. Some are extracellular, rapidly dividing, acted upon by INH, streptomycin, ethambutol. Some of them are extracellular, slowly or intermittently dividing. They were acted upon by rifampicin. Some are intracellular, intermittently dividing. They are pyrazinamide. And some of them are the dormant bacilli where no drugs act. And since there are the cluster or collection of organisms have a different division and hence acted by different drugs, and that is why it is a multi-drug combination to be given as ATT. Now, next is intermittent or daily doses. And the doses, the current drug combination is rifampicin, INH, ethambutol, pyrazinamide for 2 months. After that, pyrazinamide can be withdrawn, streptomycin, rifampicin, INH, and ethambutol to be continued in the maintenance phase for whole duration. Well, it used to be 2 drugs 3-4 years ago, but INH resistance has been demonstrated in some part of India, particularly in Gujarat, and that is why all treatment protocols now include rifampicin, INH, and ethambutol as a maintenance. Now, the next was, should we give an intermittent or daily doses? Well, this intermittent or daily doses, both are scientific. Intermittent acts on lag effect, where if the bacteria is put to some drug concentration in the blood, then bacteria undergoes suppression. And even if the drug is withdrawn, bacteria takes 24 hours to reactivate, 24 to 48 hours. And that was the rationale of lag effect. However, and that is why 3 times per week were advocated to improve the compliance, and so as to make it possible that this could be an supervised chemotherapy. However, the problem with intermittent doses was that if some dose is missed, then it becomes inadequate treatment, and that was the risk of emergence of drug resistance. So now all guidelines have says that it has to be daily doses regimen. So there is no confusion, no controversy. It is daily doses regimen. Short course or long course? Yes, this is still an unresolved issue. There are various groups to talks about 6 months, 9 months, 12 months, and this all is because of pulmonary has recommends short course regimen, because there you are able to demonstrate bacterial sterility of pulmonary lesion by sputum, repeated sputum examination, and then you give 4 months ATT, and that's good enough. However, in a bone and joint tuberculosis, it is difficult to demonstrate when the lesion becomes bacteriologically sterile. And that is why the opinion is divided between 6, 9, and 12 months, because our healed status used to be completion of regimen, whatever pulmonary group gave, and no recurrence for 2 years. And this duration of treatment, in a review of literature, we find that there is a lack of consensus what constitute healed status in the literature. So we the work is going on to define what is the end point of treatment. And when the contrast MRI was taken to decide the end point of treatment, what we found is that not all lesions, we could demonstrate 35% lesion patients achieving healed status at 8 months, 60% at 12 months, 90% at 18 months. And that is why we recommended that it is unscientific to stop ATT by fixed time schedule. Lesion must heal. So then, and this is the example you could see here. This is the lesion which is completely resolved on MRI. And this is the lesion and which is completely resolved on MRI. But then the persistent bone edema on a contrast MRI was an issue, because this edema could be an inflammation of bone or it could be a disease per se. And this inflammation, this persistent bone edema was to be resolved. So that is why MRI evaluated lesions were overtreated. So then we again monitored with PET scan, and we concluded, and these were all histologically and bacteriologically proven cases. And what we could see that again, all those same findings were, we were able to ascertain that there were some patients showing healing at a shorter time, while others showing healing at a longer time. But PET scan was able to cut short and demonstrate healed lesion earlier than the MRI scan. But one thing what we concluded, that if there is any chance stainless steel implant, then PET remains the only method to demonstrate healed status. So again, we concluded that you have to treat any spinal TB lesion till healed status is demonstrated by contrast MRI or PET scan. And this is one example. This is a classical radiologically diagnosed cervical spine lesion. And this is the classical MRI finding. So I'll just, due to paucity of time, they will not describe the finding again. And this is the radiological healing. You could see that radiological healing has started appearing. And this is on MRI also in T1 weighted. It has, the body has become brightened, so fat necrosis has taken place. And at 10 months, PET scan demonstrated no activity, and the ATT was stopped in this particular patient in that series at 10 months time. So the regimen is 4 drugs for 2 months, 3 drugs for 10 months, daily doses. Closely monitoring is to be done for development or progression of neural deficit, and all those patients who require surgical intervention to be intervened. Total duration 12 months, extendable up to 18 months on case-to-case basis if you are not able to demonstrate attainment of healed status. Now, children, the same drugs is to be given. The only thing is that you have to calculate ATT volume of the drug based on the weight of the child. Every child has to be, ATT has to be customized. And another important thing, that these children, once they are put on ATT, they gain weight. So that on every visit, by at least 2 months, every 2 months, you have to ensure that your ATT doses are adjusted. Now, the last in drug therapy is a failure of drug therapy. And this is all because of development of suspicion of a drug resistance, which I'll just talk a minute later. Now, with neural complication, early onset or paraplegia with the active disease, and the late onset paraplegia with healed disease. Now, in early onset, it is the compression which is causing the paraplegia by disease, mechanical compression or instability, while in late onset paraplegia, it is not the activity of disease, rather it is a long-term changes into the spinal cord as a result of sequelae of severe kyphosis. Now, surgical treatment, it is very difficult to talk about in detail, but indications are when you are operating for a neural deficit, or you are operating for instability, impending neurological deficit due to a panvertebral disease where the body and the posterior complex simultaneously disease, or a long segment disease where after decompression you have to span the graft is need to be spanned by instrumentation, or when a deformity correction is to be contemplated in active disease, particularly in children where we have a severe kyphotic deformity and where you are suspecting a drug resistance, you want to procure tissue to submit for a demonstration of resistance, and that is why presumptive drug resistance is an indication of surgery. And late onset paraplegia, because here the sequelae of kyphotic deformity, if you don't intervene, then spinal cord further further will be damaged, and that neural deficit will be non-recoverable. Now, instrumentation, yes, there was some controversy, but now instrumentation indications have been defined, that in a panvertebral lesion where body as well as posterior complex is disease, you have to instrument the spine. Large post-debridement defect, if you have decompressed this kind of a long segment, then graft need to be protected, or a severe kyphotic deformity is corrected, because there you have to do a posterior column shortening as well, then it has to be instrumented. And TB of junctional area, because it has a severe repercussion on the progression of kyphotic deformity and development of neural deficit, and hence it is advisable to instrument the junctional area lesions. Instrumentation type could be of any kind, and that all depends on availability, that depends on the number of vertebral body, that depends whether what is the bone health, where say for example, here we did the pedicle system, while doing the pedicle screw on the upper part, the pus started coming out, so we modified into the upper part is just taken as a hard shell, and here the whole hard shell was given. So all instrumentation of all works well if correct principle of instrumentation is used. And here again you could see such a long segment disease, and here this you could see the destruction of so many number of vertebral body, so spanning some the posterior complex of some vertebrae, leaving some, and then again. So you have to plan the instrumentation depending on the type of case. Spinal deformity is very important. As I said, if the spinal deformity heals with 60 degree or more, there are more chances of late onset paraplegia. So it is easier to correct spinal deformity in active disease. You need to identify, you need to see the natural history of that particular kyphotic, whether it is going to be progressive or not, and then you take for deformity correction. And the principle are, whenever a patient is taken for deformity correction, you have to do anterior corpectomy, you have to do a posterior column shortening, and when both are done, instrument the spine, you have to do anterior gap grafting and the posterior fusion. So this all have to be done simultaneously. This is a difficult surgery, this is a complicated surgery, labor intensive, and it has to be done by only those who are well trained and who are regularly doing it.
Dr. Anil, we are exceeding time. We are very short.
I'll just finish in a minute.
Yeah.
I think drug resistance again. We have, what I mean by drug resistance. Now this was TB lesion, and at 9 months the lesion is the same. So there has to be something wrong with this patient, and that is why these are presumptive drug resistance cases. And here line of action is that take tissue, submit for histology for diagnosis, take smear, genotypic analysis, and gene experts, LPA, and a culture to prove drug resistance. I think I will not talk about the drug treatment of drug resistance, because it itself is a big lecture, but there are certain principles that you have to read, and I'll just recommend one of my article on this, and you read that, and that these are the various definition of drug resistance. And these are more toxic drugs. They are used in higher number. You have to use certain those drugs which are less potent, but then you have to use, because that's the only way you are going to eliminate, cure the patient from tuberculosis. Now, these are the various regimen being prescribed for 1 drug resistance, 2 drug resistance, but then prevention of drug resistance is the key, and that's what you can do by monitoring the first instance when you are treating, monitor the drug resistance, drug treatment properly, so that there is no drug compliance is good at first instance. Well, in children, deformity progresses very rapidly because these are soft cartilaginous bone, and hence they have to be diagnosed early. Otherwise, in 2 to 3 months' time, they can develop such a grotesque deformity. And that is why, and this deformity progresses with growth, because even after tuberculosis healed status is achieved, this deformity is likely to progress with the growth. And that is why, and these are the severe kyphotic deformity, which may end up, some of them, with a late onset paraplegia, and they need to be corrected at first at the wet state when the lesion is active. Otherwise, these kind of a severe deformity, you are going to end up in a severe kyphotic deformity. Had it been treated at this stage when the lesion is active, this surgery would have been simpler. But with the late onset or with the healed kyphotic deformity, it becomes a difficult proposition. So friends, so we have to suspect early and treat early. Diagnosis must be ascertained at all costs. Treat adequately till healed status is achieved. Surgery, individualized indication. Drug resistance is a menace to be prevented, and children be little aggressive to make diagnosis and treat. I think these are the 3 suggested reading. This is again a article in JBJS British, and this is an American. If anyone wants PDF, because this has not come as yet, so anyone wants PDF, I can, any students can take from the students of UCMS, or else I can put on the DOA website. And this is again a drug resistant article, which is a very comprehensive article to give all insight onto the postgraduates. And in this book, there are 200 questions for the postgraduates, and the questions have been answered as if it's being put to the postgraduate student. and what you face in your clinical practice while treating a patient. So these 200 to 300 questions have been answered with the reference. So these are the suggested reading. Thank you very much indeed for patience.
Thank you, Dr. Anil Jain. Doctor, hello, everyone there? Dr. Ankur, are you there?
Yeah, Dr. Manish.
Yeah, please go ahead with your presentation, because we'll take questions later on. We have Dr. Vineet will take questions later on. We don't have time. We have already consumed 3 hours.
Okay. Sure.
Dr. Ankur, please.
How can I unshare?
Sir,
Okay.
Stop sharing just.
Yeah.
On the top.
Dr. Ankur, I want that you give a very crisp and just give the message, because we are falling short of time. So make it short.
I absolutely understand. So, can you see my screen now?
Yes, sir. You can go ahead, sir.
So can I go ahead? All right. So my job was here to, go through the management guidelines for thoracolumbar fractures. And since I think we are, reaching at 10 o'clock, what I'm going to do is, just skip through many of the slides and just talk about the basic principles about here. One point about thoracolumbar junction, why we are talking about these fractures is because this particular anatomical area is very typical in terms of it's a junction between a rigid kyphotic spine, which is supported by the ribs, with the mobile lumbar spine. And whenever there is a trauma or whenever there is a big force acting in this junction, it is likely to cause fractures or dislocation at this junction. And that is why this anatomy is very important. Dr. Sudhir and Dr. Sural have gone through the neurological examination and also through the concept of spinal shocks. I'm not going to repeat, but at the same time, it is very important for the PGs to understand that the concept of complete and incomplete injuries. A complete spinal cord injury is something wherein there is a total lack of sensory and motor function below the level of injury, and there is no perianal sensation or voluntary anal contracture. Whereas in an incomplete injury, there may be some preservation. Why it is important to understand this concept of a complete and incomplete injury? Because it does have a huge bearing on how you are going to manage these fractures. What is your attitude going to be? And also talking about the sacral sparing, which Dr. Sudhir has well covered about spinal shock. So you must understand that before you label a patient as a complete spinal cord injury, you must make sure that he is out of spinal shock, because that will make a huge difference in his prognosis and also in probably the surgical scenario. The classification of thoracolumbar fractures has been being evolving over so many years. In the last 60-70 years, the classification is still evolving. And why do we classify these fractures? As we know, is basically to communicate with each other. The classification gives us the treatment guidelines, and it also tells us about the prognostication of an injury. And for thoracolumbar burst fractures, actually, these classification systems are actually the key to management principles. So for us orthopedic surgeons, these classifications have kept evolving right from the time of Böhler, when he introduced the concept of mechanism, to the concept of stability. And over the years, we have come up with a number of classification, like the Nicol classification, or 2-column classification, or 3-column classification. And finally, somewhere in 1983, we started getting hold, and we started getting an understanding of what spine is about when the 3-column concept was introduced by Dennis et al., who divided the vertebral column into 3 parts. The anterior 2/3 was the anterior 2/3 of the vertebral body, along with ALL was the anterior column. The posterior 1/3 of the body, along with the PLL, was the middle column, and the post structures, everything behind, were the posterior column. Now, I am stressing on this part is because our management principles will depend upon the involvement of these 3 columns in different fracture patterns. So if we can identify these columns, we can identify injuries, how many columns are getting involved. They would guide us what we want to do with this, with our patient. So we have discussed that neurology is one of the most important factors to make a decision. Column involvement or the morphology of the fracture is the second most important factor in deciding. McAfee also came up with a classification. Now, the third factor which we have been talking about, the load sharing classification, was introduced somewhere in 94. This is the time when the CT and MRIs were gaining popularity all over the world. And what this classification looked like, it was basically, it came in the era of the short segment fixations, which when they started failing. So what are short segment fixations? These were fixations wherein a screw was put one level above the fracture level and one level below the fracture level. And they started realizing that some of the cases were doing very well with a short segment, some of the cases were not. So they started looking at what cases were doing good, and they realized that with this classification which he introduced, wherein he divided the fractures into three parts depending upon combination of the fracture displacement, and kyphosis correction. And he realized that according to his scale, if the score was above 6, then these patients were likely to fail with a short segment posterior construct. So this was the load sharing classification which came in 1993. The AO guys came up with their classification. We know how comprehensive these AO classifications have been, but the problem with the AO classification was that it could not be applied universally. It was too complicated, too difficult to remember, and there were a lot of studies which came in which said, like this study by Honor et al., which said that there was a very poor inter-observer reliability. So now this brings me to the last two classifications. So you can sort of, if you think the previous slides have gone quickly and too fast, that's okay. You need to now concentrate on what I'm going to present, because these are the two classification systems now which are most in vogue, and these are the ones which really guide you in deciding what sort of management you want to do for a fracture. So this classification was introduced by Vaccaro et al. It's quite popular, which is called as TLIX, which was in 2005. And it looked at three factors. One, which we talked about, the injury morphology, how many columns, what type of fracture it is. Second, integrity of PLC. What is PLC? PLC is the posterior ligamentous complex. The posterior ligamentous complex is made up of the posterior supraspinous ligaments, the interspinous ligaments, and also the facetal capsules and the ligamentum flavum. So the integrity of PLC is the second most important factor. The third is, as we were discussing, neurological status. So how did he go about this classification, and how does it help us in management? So they looked at morphology, and they looked at compression fractures, which was simply end plate fractures. They gave them a score of 1. Then they classified burst fractures, which were not only end plate fractures, but were associated with the disruption of the middle column and were called as the burst fractures, wherein there is a classically, there is a splaying of the interpedicular distance. The third type of morphology was translational injuries, as we see in fracture dislocation, which were given 3 points. And then fourth point was the distraction injuries, wherein the posterior ligaments may have torn in distraction, and this distraction injury may have come into the middle as well as the anterior column. These points were given according to the instability this injury morphology is creating. So a burst fracture would look like this. With on an X-ray, there seems to be a superior and inferior end plate fracture along with retropulsion of the posto-superior fragment of the vertebra, along with an interpedicular distance widening. If you look at the CT scans, you can see that there is a break in the vertebral body. There is a vertical laminar fracture, which is usually associated with it. So these were classified as the burst fractures. The other type of fractures were the translation or facetal dislocations, wherein the vertebral body alignment has changed and the facets have jumped or broken. And the distraction injuries were when there was interspinous widening, interspinous fractures or pars fractures on the posterior side, which means that there was the axis of rotation was in the front of the spinal column, and the spinal column was opening from behind, which were called as the distraction injuries. The injury of posterior ligamentous complex was given different scores. If the PLC complex was intact, it was given 0. Suspected injury, 2 points, and then definitely injured posterior ligamentous complex was given 3 points. The neurological status, again intact, because intact neurology was given 0 point. A complete injury was given 2 points, whereas an incomplete injury was given 3 points, because it is more important and more urgent to operate in people with incomplete injuries. So this was the table, and they gave us the idea that if the score is between 0 to 3, a non-surgical option may be given, whereas the score is above 4, a surgical option can be given. Which means that if you have a patient with intact neurology, which means score 0, with an intact PLC, which means score 0, but a burst fracture, which means score 2, you can conserve this patient. But at the same time, if you have no injury in the morphology, which means score 0, but the PLC integrity is gone, which is score 3, and the neurological status is incomplete, which is score 3, then you have to operate that patient. So it gives us a lot of idea, although it does leave some gray zones. And because there were some gray zones and still the principles were not clear, the AO system, and this is the second classification which we must remember, This system came up with, has come up very recently, which is very comprehensive, and it is involving all the factors, like it involves the morphology, the clinical factors, and the inter-observer and intra-observer reliability with this is very, very good. This is the classification system which has been given by the AO. Now it looks very complicated, but if you divide it simply, it's very easy. So if we hide this area, these are the type A fractures, which you start from the above. These A0 is minor fractures, A1 is end plate fractures, A2 is both end plate fractures, A3 is an end plate fracture with middle column, and A4 is a both end plate fractures with middle column. So this is the progression from a minor injury to a severe injury, and these are type A's. As you go to type B, these are PLC injuries actually. So when you look at B1, it's a pure osseous injury, wherein the injury is happening right from the front right up to the back, and the posterior column is failing in distraction. B2 injuries are soft with bony injury, and B3 injuries are actually anterior hyperextension injuries. The last part of the classification is translation injuries. So any fracture dislocations, shear injuries, lateral translations are coming under this. The beauty of this classification is that as you go from A to B to C, the instability and the severity of the injury increases. So you know, when you say AO type C, you know you are talking about a bad injury. When you say AO type A, it's a lesser severe injury. Similarly, when you go from A0 to A4, you know that A0 is a minor injury, but A4 is a severe injury. So it's very easy to communicate, and the treatment also depends upon the classification. Then there are factors, which neurological factors, which gives different meaning to different neurology. Then there are modifiers about whether a tension band is broken, not broken. So it gives a lot of description and helps us in making a decision. This is the algorithm which they give for now going through the classification and deciding what you want to do. So you have to ask just 4 basic questions. Do I see any disruption in the alignment? If you don't see any disruption in the alignment, go to the next step. If you see a disruption, it's a type C. The second is, do I see a distraction in the posterior tension band? If there is a distraction, the tension band is broken, it's a type B. If it is not broken, then you go on to the next type, which is the type A. In type A, you see if there is a vertebral body fracture or not. And depending upon whether it is only end plate fracture or middle column fracture, you can divide them into compression fractures, split fractures, incomplete or complete burst fractures. So basically, going by the principles, all stable fractures.
Dr. Ankur, please summarize.
Yes, this is the last 2-3 slides, sir.
Okay.
So all stable fractures, which are the compression fractures and stable fractures, can be treated conservatively. However, unstable fractures, which are usually AO type B or C, or flexion distraction injuries or translation and rotational injuries, they will usually require surgery. So basically, we need to establish the stability part of the fracture. Stable fractures can be conserved, unstable fractures need to be operated. There are different decision-making factors, as we discussed. How do you do a non-operative treatment? So if you want to conserve a patient, you can give him a short period of rest for 5 to 7 days. Then you can get standing x-rays at 15 days. And if these standing x-rays show that it is unstable, you go for surgery. If the standing x-rays are looking reasonably stable, you can brace them and continue these braces for 3 months. On the other hand, for surgical indications, anything which is type B and C, a loss of height of more than 50%, a kyphosis of more than 30-degree local kyphosis, or a canal narrowing of 50% requires surgery. The last thing about approach, majority of the fractures can be dealt from the posterior approach. There are certain fractures which are really bad, with really bad combination and the fragments getting into the canal and occupying a significant amount of canal, may need to be dealt with a combined anterior and posterior approach. But more or less, the workhorse approach for these fractures is posterior approach. The last slide is about the length of the construct, and with this slide, I'll end the presentation. So there has been a lot of talk about how much instrumentation needs to be done, what levels need to be instrumented. So classically, we have been talking about short segment fractures, short segment constructs, wherein the screw is put one level above and one level below the fractures. But we know there are high failure rates with it in certain classification types. So the concept of long construct came, wherein people started putting two level screws up above and level screws below. The failure rate is down with these constructs, but the problem is they are too long. They cause a lot of stiffness and sometimes back pain to the patients. So now what is gaining popularity is the fracture segment construct, wherein we try to negotiate pedicle screws into the fractured vertebra itself and then put a level above and level below. So this gives us enough stability and at the same time doesn't compromise too many motion segments. So depending upon the neurology, depending upon the PLC injury, and depending upon the intactness of PLC, we can take a call what sort of surgery we want to do. I think I'll end up here. Yeah.
Thank you, Dr. Ankur. We'll take Dr. Abhay Neri's lecture now, and then we go in for questions if we have time. Thank you, Dr. Ankur, for a very nice presentation. Dr. Abhay Neri.
Thank you.
Dr. Abhay, you are not audible.
Am I audible now?
Yeah, you are audible now.
Yeah, thank you. I said dinner is over and it's time for desserts. But when this case comes to PG student in the exam, he or she is completely at sixes and sevens in trying to answer these questions. Most of us don't even know if it's a kyphosis or a scoliosis, and you'd rather have hoped that you got a lumbar canal stenosis as your long case. But trust me that the symbol of orthopedics is a scoliotic tree, and orthopedos means straight child, so it refers to scoliosis. So I'm making my case to say that the good news is it's the easiest case. It's a great long case to have. It's a gold medal case if you ask me. The second good news is that I'm sharing this presentation with all of you on WhatsApp and all other places, so you can casually rummage through what I'm talking about. To get to the point, scoliosis has been defined by the Scoliosis Research Society as a lateral curvature of the spine of more than 10 degrees. And as surgeons, you will see scoliosis as this. So it's famously seen as the hunchback of Notre Dame, but in truth, it's actually a three-dimensional deformity. It's not a single plane curve, but it's actually a curve in three planes. One is what you see front on or on the coronal plane, which is a C-shaped curve. On the side view, you see a hypokyphosis. So unlike a common perception, it is actually a flat back or a reduction in kyphosis. So typically a scoliosis, which is an adolescent idiopathic scoliosis, the lordoscoliosis rather than a kyphoscoliosis, must remember that. And in fact, it is actually a rotational deformity. So all of you will do well to imagine a scoliosis as a stack of carom coins that have been twisted up in the middle, and that twisting has led to the spine, to bend over in multiple planes. How does this spine bend? So to clear this confusion, you should look at this diagram at the bottom right. Always remember the vertebral body shifts towards the convexity and along with it pushes the rib out, and hence the rib hump and the rotation of the vertebral body is on the side of the convexity, while the spinous process points to the side of the concavity. How do you determine whether this is a true kyphosis or a true lordosis? Run your thumb along the spinous processes and you'll see that the furrow is quite deep. The spinous processes don't pout out. Some definitions that you need to know: a structural curve versus a non-structural curve. A curve that is that has a lot of intrinsic changes, like the bone is rotated or the bone is wedged, or a curve that does not straighten up on bending is a structural curve, while the other is a non-structural curve. Another definition is major and minor curve. This is an English language definition. A curve that is larger is always the major curve, and the one that's smaller is always a minor curve. And hence, you guessed it right. If there are two equal curves, it's called a double major curve. What about compensatory curve? So when the child bends, there's another part of the back which is a flexible structure which tries to balance this bend, and that curve which is trying to balance the center of gravity, that's called the compensatory curve. A fractional curve is a curve which is only 1/4 a circle, while a full curve or a regular curve is one that's at least half the curve. These are quite colloquial definitions. This is important. What is decompensation? So a scoliosis that takes the head outside the line of gravity is a one that is a decompensated scoliosis. So if you drop a plumb line, you need to carry a plumb line to your examination room when you go for the exams. It's just a thread with a weight hanging at the bottom to aid gravity. So if you put the top of the thread on the vertebra prominence and drop the plumb line down, if it's beyond the natal cleft by more than a couple of centimeters, this is a decompensated curve, which is bad news because gravity alone will increase this curve. typically AIS increases with growth. But if it's a decompensated curve where the center of gravity is shifted, even after growth stops, this will keep on progressing. Quickly to tell you about what these confusing names are, because you will be asked this in the exam. Strategic vertebrae are vertebrae that actually make the deformity. So when you look at the Indian cricket team, there's a whole bunch of guys there, but your eyes only look for these big guys, right? So similarly, they're big guys in a curve, and these are the end vertebrae, apical vertebrae, stable vertebrae, and the neutral vertebra. So the end vertebra, this definition you must know, it is a maximally tilted vertebra on either end of the curve, as you can see in this pictorial. So each curve in a spine, every spine has 3 curves. So this spine has a curve on the top, a main curve here, and a curve at the bottom. So make a habit of looking at every spine divided into 3 parts, and you'll start seeing those 3 curves. So every curve has an upper and a lower end vertebra. The lower end vertebra of one curve could coincide with the upper end vertebra of the other curve. So in a spine, you could have a maximum of 6 end vertebrae and a minimum of 1, 2, 3, 4 end vertebrae. I hope that's clear. To identify end vertebrae, you look at which bone is most tilted. Like here, you can see the L1 seems to be most tilted. But if there's any doubt in your mind, draw lines that are along the end plate, and you will see that these lines diverge into the convexity of the curve. So if these lines turn parallel, it means that these 2 bones are equally tilted, which means the L1 would be the end vertebra. And in fact, if the lines converge towards the convexity of the curve in question, you've gone into the next curve. So in a situation like this, the L1 would be the lower end vertebra of the main thoracic curve. I hope that is very clear. When you do bending x-rays, these end vertebrae change. However, end vertebra for a given curve is like the name. Your name will not change whether you're in Bombay, Delhi, or North America. Similarly, once end vertebrae are defined on the standing AP x-ray, you cannot change that name. And hence, end vertebrae on a bending x-ray are called intermediate vertebrae. These are important to know because these are the bones between which the segment of the scoliosis is stiff. And if and when you're doing surgery for this patient, you have to work harder on this segment. What is the apical vertebra? The apex of the curve is the apical vertebra. This is invariably the most rotated, but curiously, the most horizontal vertebra, as against the end vertebrae, which are the most tilted vertebrae. Sometimes the end vertebrae could, the apical vertebra could actually be a disc. So how do you know which is the apical vertebra? You draw a line that is perpendicular to the central, draw a central sacral vertebral line, vertical line, which is a vertical drawing from the middle of the sacrum, and draw a tangent to it along the curve. And where the tangent cuts the curve is the apex. So in this particular case, it's cutting the curve at the disc rather than a bone. So in this case, the apex of this scoliosis is actually a disc and not the bone, which means that this scoliosis has 2 apical vertebrae. What is a neutral vertebra? End vertebra alludes to tilt. Apical vertebra alludes to apex. Neutral vertebra alludes to rotation. So a rotation of the bone is looked upon as a face of an owl. So when you look at an owl, it's got 2 eyes, which are the pedicles, and a nose, which is a spinous process. So when the owl is looking at you in the eye, the nose is in the middle and the eyes are equally spaced. The minute the owl starts to turn his face around, one eye looks bigger and the other eye looks smaller, and the spinous process starts looking bigger and bigger. So rotation is been defined by Moe based on the this presence of the spinous process vis-a-vis the pedicles. What about the stable zone? You may be asked, this is an engineering concept. The zone in which the line of gravity falls. So if you draw 2 vertical lines from the L5S1 junction, that is a stable zone. It's important if and when you do an operation to start and finish your surgery in this stable zone, else your tower will be erected outside the line of gravity and it will tend to fall off on one side. Stable vertebra is the vertebra that is best bisected by the mid-sacral line. Again, this is self-explanatory, and your lower instrumented vertebra should safely be the stable vertebra. So if you stop your surgery here, your entire tower will be erected obliquely and it will fall off. So end your fusion at the stable zone. If you do not end at the stable zone, as you can see in the diagram, the entire fusion will fall off on one side. So you should know your strategic vertebrae, because if you reach the point of an X-ray in your exam, which means you're probably getting a gold medal, you will be asked this, and this is Pakka gold, right? Now, this is the key part for a postgraduate, history taking in an AIS. The specific questions that you ask in an AIS case is age, because younger the child, the more likely he's going to progress. Growth spurt, so when did the child achieve menarche or puberty? birth history? Was there a difficult labor or anything specific? Brothers and sisters who are suffering from a similar condition? When was the curve first noticed? What's the progression of the curve? Has it been rapid or has it been slow? Remember, chief complaints and the onset, duration, and progress of chief complaints. If you follow this mantra, all your cases can be dealt with. So what complaints do you ask? So a typical case of an AIS will have none of these complaints. So if your child complains of any of these, of course, back pain, everyone complains of, but anything else like weakness, numbness, significant pain, dysfunction, breathlessness, it is not AIS, remember. AIS patients only complain of cosmetic deformity. Now that is not enough. It's not good enough to say my patient has presented to me with a cosmetic deformity. You have to specifically ask what part of the deformity bothers the patient. And when you give your final diagnosis, this should be a part of your final diagnosis. So when you look at the patient in the clinic, you look at the neck tilt. Again, this is a very useful slide. And if you can just describe all this to your examiner, rest assured he's not going to take you any further and you're going to be a pass, right? So neck tilt, trapezius fullness, shoulder height, chest deformity from the front and from the back, arm trunk distance, truncal shift, flank crease, pelvic tilt, limb length discrepancy and attitude, and neurology. If you can allude to all these points in your final diagnosis, you're mostly sorted. And these are the specific areas that you want to look for. You always examine a child of scoliosis in the sitting, standing, and lying down position, and you examine the gait. It's important because if a scoliosis disappears on sitting, it means this scoliosis is secondary to a limb length discrepancy or an infrapelvic pathology. If the scoliosis retains itself on standing and sitting but goes away on lying down, it's because of a painful stimulus, which means that it's a spasmodic scoliosis. So it's important to examine these. You examine gait because hip and knee pathologies are visible in a gait when the child starts to walk. So I hope this is amply clear to everyone. When you look at a rib hump, the method to identify the rib hump is the 2 textbook method, where you make the child bend at about 90 degrees and look at him tangentially, look at her tangentially, put 2 textbooks tangentially on top and see the distance between these two. But today on your phones, there are gyrometers available and there's a Scoli Angle Pro app, which you can use to actually calculate the angle. Of course, examine the spine range of motion and everything that your fantastic mentors have told you in the initial lectures. Which are the curves that are likely to progress? So you will be asked, what are the red flags in a scoliosis? A younger patient, a patient with a Risser sign of 0 to 2, a male patient, sorry, this says female, it's a male patient, a patient who has a family history, a cob angle that's higher, a rotation that's more, and double major curves are known to progress faster. What about X-rays? They will ask you, it has to be a 3-foot standing film, a 36-inch film, which will be taken from 3 feet away. Don't miss the lateral film. So it should be an AP standing film. The most important, second most important is the lateral film. When you look at the X-ray, you want to look at the end vertebrae. You want to calculate the cob angle. That's the angle between the end vertebrae. And you got to look at the riser sign, and you got to look at the rotation of your end vertebrae and your apical vertebrae. And if possible, describe your stable zone. And that should do the trick. The next X-ray that you ask for, so AP standing, lateral standing, and then supine bending X-rays. Remember, these are not standing bending X-rays. These are supine bending X-rays, which tell you about the flexibility of all 3 curves, not just the main curve that you see, but even the lower curve, which is important in planning. In case on an X-ray, you find that the rib is actually abutting against the ilium, you do what is called a traction film. For example, in this X-ray, you find there's a lot of space between the rib and the ilium. So here, a bending film will give you a true sense of the flexibility of the curve. But if the rib is hitching against the ilium, you do what is called a traction film, and that's more common in your kyphotic neuromuscular scoliosis, and that will tell you how the correction is. Look for pelvic obliquity, make the child lie down and examine the hip. So in your final diagnosis, all these should be covered. The cause of scoliosis, which side is the main curve convex to? Is it a single or double major? Is it compensated or not compensated? What are the likely end vertebrae? What's the likely cob angle? Is it kyphosis or lordosis? Is it a big or a small rib hump? Is it rigid or flexible according to you? What is the age and growth potential of the child? What is the pelvic obliquity? And point number 12, why has the child come to you? What is his complaint? What is her complaint actually? And in any of these are the classic red flags where you would suspect that this is not an idiopathic scoliosis. A younger child, a left convex curve, a male child, rapid progression in the scoliosis, skin signs, neurology, pain, or a family history. All these would make you suspect this is not idiopathic scoliosis and get an MRI scan done in all these cases. Of course, when you classify scoliosis, I'm going to skim through this because this is all there in your books. There is dystrophic scoliosis, which is typically neurofibroma. There's degenerative scoliosis, but you got to know the King's classification, and I have a simple trick to remember the King's classification. Number 1 and number 2, type 1, type 2 are T and L double curves. Type 1, T is small, L is big. Type 2, T is big, L is small. Type 3 and type 4 are C-shaped curves. In type 3, L3 is in the midline. In type 4, L3 is outside the midline. And 5 is a double thoracic curve. So it's quite easy to remember the King's classification. It's much more difficult to remember the Lenke classification. And I beg you not to try to remember this classification. You'll forget everything else. So just remember the principles that Lenke classification teaches. It tells you that every curve is made up of 3 parts. So even though one curve is staring at you in the face, look above and look below before you decide what kind of a curve this is. So divide every spine into 3 parts. The second thing it tells you is look at the sagittal profile of every spine. Don't just be happy with the lumbar, with the AP view. And the third thing it tells you is that identify and subclassify your lumbar curve, because that's what's going to tell you how low you need to go when you do surgery. And quickly to come to management principles of scoliosis, the idea of surgery is fusion, and the surgical limit is most cases after a 40-degree angle of Cobb's are considered surgical, but the child should want the operation. There's no need for the operation, there's a want. So if someone comes saying, I'm feeling happy with myself, you don't need to offer surgery. It's a purely cosmetic surgery in adolescent idiopathic scoliosis. Because the surgery alludes to correcting and fusing the spine, you're halting growth, and hence you want to delay surgery as much as possible till you can get maximum growth in height. The ideal age for surgery is, of course, after growth is achieved, which is about 2 years after meniarchy. But the closer you can get to this is better. 40 degrees is the cutoff for surgery, but this is not a rule that's cast in stone. There are variables. A 30-degree curve, which is decompensated, may still become surgical. They will not typically ask you indications for surgery. All that you need to know is that indication of surgery is if the child is unhappy, which is cosmesis. You don't get respiratory problems in idiopathic scoliosis. You get respiratory problems in neurofibroma, in high-grade syndromic scoliosis, and in cases which have deep kyphosis. The surgery is done by posterior instrumented correction. So you put anchors, and the methods of correction are translation. So you put anchors in the spine, screws in the spine, and pull the spine to a straight rod. As barbaric as it may sound, it works. The other is the cantilever technique, when you push the rod against the spine and correct the rod using anchors. So that's the cantilever technique. And the third is the derotation maneuver, where you put a bent rod and then twist it around in a way that the spine corrects. So a bent rod is then twisted to make it look straight, and that makes the spine straight and makes the spine nicely curved on the side view. And that's the kind of correction you get at the end of the day. So finally, to sum up, when you make your diagnosis, you say which type of a curve it is: left, right, convex, thoracolumbar, lumbar. You say whether it's compensated or decompensated. You ideally talk of the end and neutral vertebrae. You talk of whether it's kyphotic or lordotic. You talk of rotation and rib hump. You talk of flexibility to the in your final diagnosis. You talk of the remaining growth potential. Sum up the pelvis and the hips, and finally make your diagnosis with all these 11 points. The point number 12 being, and sir, this patient has come to me with the chief complaint of a rib hump that irritates the patient. So my take-home message is, identify your scoliosis well, give your diagnosis in the 12 parts, and get a gold medal. Thank you.
Thank you, Dr. Abhay. We have only 5 minutes. Thank you for such a good, nice lecture. We have 5 minutes. I will take few questions from the audience and then we wrap up. Dr. Shankaracharya, are you there? Dr. Shankar? Dr. Shankar? Okay.
Sir must have left.
Dr. Abhay?
Yes.
There is a question for you. How to check for spinal balance? First question, and second is spinal flexibility, 3-point bending concept.
So spinal balance is by the plumb line. You take a rope with a weight at the bottom, put the rope against the vertebra prominence and let it drop down. And if it falls within the natal cleft, the gluteal cleft, within 2 centimeters of that, it's a balanced spine. If it's going off, it's an unbalanced spine. That is in the AP view. On the on an AP, and on the lateral, you drop the plumb line from the tragus. It should fall within the center of the trochanters. The second question was
A 3-point bending concept.
3-point bending. So sometimes when you do a bending X-ray, your ribs come in the way of, and the ilium gets abutted, and you can't then bend any further. So you get false or inadequate information. In such a situation, if you can put a fulcrum at the top of the C and put a fulcrum and then bend over the fulcrum, you get a much better bending X-ray, and that's called a fulcrum bending X-ray, done in specific cases where there's an abutment of the iliocostal junction.
Okay. Dr. Shankaracharya.
Yes,
Dr.
sir.
Shankar, can you tell about failed back syndrome?
Well, it's you have to have another seminar on spine because
No, just short. They want ki you are not touched about the failed back. So just briefly, you can tell them.
well, I think the terminology of failed back should not be used. Number one, I think it should be called revision back surgery. I think failed back is not the terminology to be used because after a surgery which has not worked for a patient, there are many options that there are many reasons why this should happen. One is identifiable cause and one is unidentifiable cause. When we do spine surgery, a lot of causes of spine surgery are linked with psychosomatic illness behavior and other compensation behavior. So if a patient's surgery fails, first what we do is we need to investigate and assess the history all over again and go through it all over again to see and investigate him or her with again set of X-rays, MRI to see if we can find an identifiable cause of why this surgery failed. And about 60% of cases, you will have an identifiable cause. And if you rectify that cause, it will work. So it's just like a femur non-unions. You don't call femur failed. You call surgery needs to be revised because the surgery didn't work. But there will be about 30-40% of patients where you will not find an identifiable cause. And in those cases, you will have to try all conservative methods first. And failing that, then you may use, there are special methods called spinal cord stimulator and things like that, where you can confuse the brain, which is the pain receiving source, of from where the pain came. So we do use spinal cord stimulators in some situations. And that is basically in concise about failed back.
But I want to add a 2-bit. Failed back happens in 3 situations: wrong diagnosis, wrong patient, and wrong surgery. So if your diagnosis is incorrect, you get a wrong result. If your patient choice is incorrect, and if your surgery is incorrect.
Very true, very true. So I thank all faculty, and you are great because you sat for, we took 3.5 hours. So already have we passed. So I request Dr. Sharad and Dr. Hitesh to do the closing remarks. Dr. Sharad.
Yeah. I must congratulate the whole team, the whole eminent faculty. They have given a very excellent disposition. I think we as well as the audience will never be satisfied, but things have gone for too long and have to be stopped at some level, some stage. I think Dr. Manish Dhawan, we should have another seminar on spine sometime in the future.
No, we will have only case based. Normal, like we will have a student who will take a history, he will examine, totally recorded. We will not have any lectures that time. So for hip and spine, we will have a proper this thing.
Right.
And Dr. Hitesh, are you there?
Yeah, I would like to thank the faculty, and each and every lecture was very meticulous and comprehensive, and it was a very nice listening to each and every lecture.
So all these lectures will be available on the YouTube, and we'll send you the recording. And I thank the whole faculty. Dr. Kamran, you are very nice. You are the opening batsman, but you stayed
thank you, sir.
3.5 hours. Dr. Sudhir Kapoor, Dr. Sural, Dr. Shankaracharya, Dr. Vineet was also involved.
Especially thank Abhay, because Abhay has been doing webinars since morning, and I have been for his last 25 days. He's always on the net. I don't know how he has this patience. Amazing.
Yes,
he is not doing anything else other than the webinar.
I'm not seeing any COVID patients.
No, webinars and singing also. He posts every day.
Exactly, sir.
Okay.
His guitar is still visible.
Yeah. And finally, I thank Dr. Shamsul Huda and Dr. Ravi Chauhan for providing the technical support. And thank you, everyone. Dr. Ankur, thank you.
Thank you, everybody.
Take care.
Thank you, sir.
Thank you so much.
Take care.
Thank you, sir.
Thank you.
With your permission, I'm stopping live stream, sir.
Yeah.